Okay, so I'm going to go through the screening tool in our data collection sheet, and Haley's going to be passing out what it actually is so you can see and have an example of it. This is going to be a Scantron format, so you don't have to enter data into the system. You're just going to batch it all and submit it, and Haley will walk through what that process looks like. We do have specific instructions. The main thing when you see this, there are check boxes. You either, we're just putting a check for one per box. So by having that, it will be captured really easily within the system using a pen, and all your data will be viewable and accessible for our run charts. We're going to be walking through how many of you brought your process maps or have an idea. Perfect, right? Okay, so we're going to walk through what things currently look like, have a little bit of an example of how we're going to complete the tool and different rules that we may have. But it does take a group effort to make all of this happen, be it the caregiver that's answering it, and where we're going to provide it to them, who's going to be scoring it up, so the provider that goes in with the family knows what they have to address, and then looking at how we are providing resources and continuing to have conversations and putting some process checks in place that will help make sure that all these pieces happen appropriately. You are going to get sick of me referencing this and putting this up on every single action period call, but this really drives our effort and what we're trying to accomplish. So we have our SMART aim and our global aim that we're looking to improve over these coming months by getting this screening tool into place and working to ask questions about the child's exposure at all birth through 1-year-old well child visits. And you'll be able to do that with the top section. If you're looking at the tool that she's passing out, it's really those bottom 2 questions that help us get at that asking whether there's someone in the home or that actual caregiver that's in the office that is smoking around the baby. We're working to advise and assist in smoking caregivers and others in the home by offering them smoking cessation or vaping cessation resources at least 80% of the time. And then we're arranging, and this is something that we're emphasizing more in this iteration of the collaborative referrals for the caregiver that's smoking, primarily to the Ohio Quitline, but we do have other resources that are available for that individual to help the system process. And then we've learned from the evidence base and the literature, as well as the lessons from previous participants about what works and what doesn't work. And those are our interventions that we have listed on the right-hand side of our key driver diagram. And we'll work through to see if we have a foundation of these, or if we need to build that foundation and scale it up and get you into place to go through all of the 5 A's using this tool. There are a couple pieces to this. To get the data to us, we have a cover sheet. This is important in terms of, laser up there, maybe halfway. Okay, so there's 2 features here that we really just want to make sure that you are paying attention to. It's a time frame of the well child visit. So when we're looking at how well you're getting the screening tool into place, the well child visit dates. So if you're batching every week, you can go Monday to Friday and those dates there. But also with this last section, the number of visits that were attended. If not all your providers are participating, we need to make sure that those numbers match. Otherwise, it looks like you're not giving us enough screening tools for the well child visits that you submitted. So just making sure those numbers jive and you're appropriately capturing participating providers and screening tools to help get us up towards that point of having appropriate attendance and use of the screening tool at those visits. The caregivers will have a brief kind of elevator speech about how to complete this form, and there's a cover page that goes through this. It walks through the correct way to fill in the response, and I indicated that we'll be using a check mark to do that, and we're just going to streamline that and say that's one option for going through to complete this, and not to fill in the whole box or put an X mark. And using black or blue ballpoint pen. So there are several things on the screening tool itself. We have the first 8 questions that look at demographics. So we are encouraging that this form goes out to every single well child visit birth through 1 year of age. And by doing so, there are certain features here that when we cluster them within the practice and the participating provider, match that individual child so we can see if there was a reduction in smoking or cessation within that family. So this is important that these are filled out, and we try to match them as closely as possible, given it is self-reported data. Then we have the safe sleep and the smoking screeners. Those are questions 9 through 11, and these are going to help prompt what you do on the reverse side and the provider and the caregiver provider section. This is where we need to also put some steps to to check and double check that what they're putting in terms of when they smell smoke on them, that they indicate that they don't smoke. Or you're talking about safe sleep and they indicated that they did do this. So just kind of making sure the conversations match with what's on the tool, as well as the reverse side with questions 13. If they indicate that they're smoking, just kind of conversation about what that looks like versus if they put the number of items or vapes that they have smoked and selected no on the front, that we have some kind of match or mismatch just to make sure that the two correspond with their smoking status. On the second side of this, this is where our use of 5As come in. So based upon the caregiver's response about what their level or thoughts about quitting are, we have two different ways to approach this. For anyone that indicates a 2 or above on this readiness or willingness to quit, we then give them certain handouts. For data on our reduction and cessation, that's where the numbers are going to fill in the quantity that they smoke or vape or puff to capture. We can see discrete changes in those repeat visits over the course of the collaborative. And then quit attempts, this just really indicates what they're doing on the continuum of their quit journey. And you can certainly have this conversation in reference between the two. So then you as a providers that are having a conversation, there are certain things that we want to look at here. So we need a process in place for helping make sure that what answers they give on those screening questions for safe sleep, if that individual smokes or others in the home smoke, are captured on this first row. So we know if they should be discussing safe sleep, if we should talk about the caregiver's smoking or vaping status, if they should refer them to the quit line because their level of readiness is at 2 or above, or if there are other individuals in the home that are smoking. We also need to make sure that the provider that is completing this or having a conversation with the family has their initials checked appropriately. This is how we make sure that you're providing screening tools and can track your progress for getting MOC Part 4 credit. And this also helps us match individuals in case they should see the same provider within the practice. So there are a series of resources that we have available to you and that you'll be going home with. We have some talking points. One of the things that I want to emphasize here in this row for advice and advising the patient is attempted discussions. You may open the conversation with the family about quitting smoking and they may shut you down. But you have attempted to have a conversation about quitting, offering resources or whatnot, then you can select yes, I attempted to have this conversation. You may not need to continue or have that full conversation, but you at least try to. And that counts for both discussing with the person that's actually in your office about their smoking status or about someone else within the home that may be smoking. We have resources. So very similar to attempting to have a conversation, you're offering resources. You could say, I have X, Y, and Z available to you, and you can take these home or look at them. You've offered them, you can select yes, you provide the resources for the caregiver or others in the home. They may not accept them or they may throw them in the trash when they leave. That's their choice, but you at least tried to provide them with some resources to take home and to explore. And then the referral to the quit line. So that final step for the caregiver that's in the office that's screened positive for smoking is offering the resource of the Ohio quit line or another quit resource for them to go forward and work on their cessation journey. So some general reminders prior to scoring the tool, review the caregiver portion, make sure that it's completely filled out, check boxes, double check the screening questions that are 9 through 11 with the amounts that are smoked or vaped and the locations that they may be doing that, just so we make sure we have that information captured. And then there are talking points that are highlighted as the nurse or the MA goes through, yes, you should talk about safe sleep, or yes, you should talk about smoking or vaping, and you can pull those handouts to have at the ready. And then always making sure you fill out, we had an initial box, but checking your initial box so that you get your credit for doing the screening tool, reviewing the column or the row now with who should discuss what and when, and then documenting what happens with them. If you attempted something or you offered something, give yourself credit where credit is due and make sure that's captured here.
And even one that I was just noticing as we were filling it out, like doing our practice run, is really being thoughtful maybe in your upfront conversations, whether these are being handed to the families by your front desk office or your nurse or whoever, about making sure even if the answers are 0, that there's something being marked off. I mean, I was noticing that some of them weren't always being filled out, and understandably so, especially if you kind of think of how chaotic a waiting room may be or wherever they may be filling these answers out, because I believe, and correct me if I'm wrong, our stats guru who takes all of these information, all these scantrons that get scanned, but anything that's not filled out doesn't get noted as a 0, it just gets noted as missing information, correct? So sometimes it may be the nurse that first notices that, oh, you didn't answer question 12. Let me walk through this really quickly and see what your answer was, so that we can at least put a note for that particular point. But I'm gonna need to move over here just so I can see what I have on these slides. But there really can be, we certainly hear from other previous waves, and just as a clinician in the office, I can kind of see these happening within my own practices as well. Some potential barriers, and we want to at least throw out some potential solutions, or maybe some potential solution jumping off points for you, knowing what your clinic space looks like and how your flow works as well. One of the very common barriers and challenges that we hear from clinics is there's just so much darn paperwork that people are filling out, especially when you think about a well visit, 0 to 1, and all the various sort of things and screening tools that we do. And this really is one more added piece when it comes to that paperwork piece, which is why Sam was kind of mentioning that the way that we solve that in one clinic versus the other may be different. And it doesn't even necessarily need to be in a paper form, in the sense that maybe for your clinic flow, it really is about a nurse going through that, or during the check-in process or the triage process, and MA going through those particular questions. Or maybe it's just a great opportunity for us in our clinics to be thinking about what we have been doing. And sometimes, you know, it's those old things that have been going on for a long time that we're still doing and don't necessarily add value to what's happening in our clinics. And this just gives us an opportunity to sort of re-examine that. What are the documents that are being done at the 2-month or the 9-month or whatever the case may be? And are there consolidation options too? This obviously is a very sort of specific screening tool for a very specific reason when it comes to this quality improvement project. But especially as we talk with practices who have gone through this QI project and now are, 6 months, 12 months out, they're not using this full screening tool, but they've been able to sort of consolidate, especially down to like the 1, 2, maybe 3 questions that really are like the sort of most important pieces that allow them to know where to take conversations with during those visits. Some clinics may even become more creative, depending again on how savvy your particular clinic may be in terms of your EMR patient portals. Some clinics are using those as sort of pre-visit screening that's happening beforehand. It may not end up being successful for 100% of your patients, but it may right off the bat be able to take off a chunk of them that are already done before they even hit the waiting room. And just from a sort of quality improvement, how do we get anything done consistently and standardly in clinics? It's a great reminder of the value of things like pre-visit huddles or clinic day huddles, in terms of already sort of eyeballing who we think are going to be going to need this or that, or we're going to need to sort of address this issue or that issue. But what we do hear from clinics, especially who have gone through this particular quality improvement program, is that designating really clear roles within our office staff, who is literally going to be the person giving the families these screening tools, who is literally going to be the person who's sending the reports off to have the data collected. All those clear roles and some backup options. So if that person is out on vacation or things change, that there's a few sort of steps layered in there so that that you have sort of all these options covered. Another sometime potential challenge that we've heard from practices going through this process is scoring the screening tools specifically to identify those risks. And that was that first sort of layer row in the provider portion that you guys were filling out. I don't even know what I did with my forms. But you saw, you got to practice this yourself in terms of, you know, how does an MA, or if it's going to be the provider or whoever's going to be actually doing that scanning, what they need to do in terms of looking back and forth. A little cumbersome sometimes, but it really does hopefully give you at least some clear guidance. You should go to question 9 to answer this. You should go to question 10 to answer this, which also sort of highlights the importance of making sure that you have answers to all those questions. So that's a really wonderful opportunity for the MA to potentially realize that that particular question was accidentally skipped over, and let's just ask that question to the person, to the family right now, so we can get an answer. And then same for the provider scores. We didn't really score the bottom portion of that. But again, different practices may decide that they're going to have different processes to do that. Sometimes it really is the physician at the end of the visit who fills that sort of last few questions out. Sometimes it may be the MA based upon that conversation that they had with the physician, or the physician doing at the end of the day, whatever the case may be. But though all of those questions being answered really drives what data the GRC gets, and really at the end of the day helps decide if it was done correctly and if that data is useful or garbage, in terms of us being able to give you some really useful feedback when it comes back to the quality improvement portion. Another real nice benefit of the QI program is the resources that we have available, but it's also can be sometimes tedious in terms of thinking out how do we organize all those resources and give those families the support services that they need. So again, different clinics find different strategies are useful to them. Some of them already sort of have them packaged in almost like kits, so that if they have a 0 to 2 year or like a particular well visit coming in for that day, it's already in the chart or sort of attached to the chart in a way that is sort of ready to be used. And if it doesn't get used, it gets to kind of be put into the recycle pile or the file it back in pile. And is it the MA who grabs some of those, or is it the front staff who's pulling those together? Or is it even just that they're in the exam room with the clinician, so the clinician can kind of pull the resource they need depending on how the conversation goes. And then the quit line, which we haven't looked at yet, and I don't think Haley had an example. You didn't print out a quit line.
So in the back of the packet, there's actually samples of almost all of the handouts. We have one that's still in revision, but there is a quit line form through this back pocket folder.
Perfect. So if you can turn to your back pocket folder and find the form that says quit line referral, just so you have a sense of what that looks like. Because this is the referral form developed by the Ohio Tobacco Quit Line that helps to basically put in a sort of formal process in place, so that if a patient is in your clinic and they're saying, I'm ready to get some help to cut down or to quit, we can send this referral form, fax it, that referral form directly to them, and they then reach out to the family, to that person, to contact them with both the behavioral health counseling, and there is the option for free nicotine replacement therapy as well with this. So this is a form that you as a clinic can use to help streamline, sort of minimize the hurdles of that patient themselves potentially calling the referral line, which is another option for them. But you'll see that up at the top portion of that Ohio referral line is information that's specific to you guys in your clinic, your office, address, phone number, all that sort of stuff. And then the second sort of part is the part that's specific to the family or to the adult or adolescent, potentially parent that's in your office. So their name and contact information. There is an option for you as a clinician if you have sort of already assessed that adult's readiness or ability to use nicotine replacement therapy that may be specifically relevant for those of you that are coming from family practice clinics or med-peds clinics, where that is something that you feel very comfortable with. You can sign off on that, giving basically the Ohio quit line the sort of medical authority to say, yeah, this is a patient we can give nicotine replacement to. And then there's a place for the parent or that adult to sign and say, yep, I'm agreeing to this referral. But I mentioned this referral form because, one, part of the goal of this QI program is not just to hopefully have a lot of conversations in our clinic with patients, but to literally line them up with even more resources beyond what we're going to be able to offer in the clinic setting as well. And the referral line is one of those. And again, one particular challenge and potential solution we've heard from other practices is the more of these referral forms that we can sort of already have pre-populated, particular that portion up front, the easier it was for clinicians then to have mom or dad sign the form, put their contact information, and that was, you know, at the end of the day when they faxed their data to GRC, at the end of the day they faxed their QuitLine referrals to QuitLine. So that may not be the solution for your clinic, but it certainly is one way that a lot of clinics were able to help streamline this particular process. Again, it sort of begs the point about designation as well. Clearly then, who is going to be the person to help make sure that this family signs that form and going to send a QuitLine referral form and things like that.
Those go to a different fax than the
Exactly, yes, because those are completely separate places. This just happens to be a resource that the state has that we're taking advantage of. But as I was mentioning, that resource, once it gets sent to them, your part is done in the sense that the QuitLine will contact the family or that patient directly for the resource. Roll in again here. The only other thing I was going to mention before I hand it back to Sam has to do with the quantifying this whole quality improvement work that you're about to embark on over the next few months. And that is basically, how do we get these screening forms to the people who are actually going to collect the data for us. And that comes with, like I said, luckily one of the real great benefits of that we hear from other practices who have gone through this wave is how really nice it is to have it at least on a screening form like this, because then all the data is actually collected at the time of sort of the visit itself, and you're just scanning those or faxing those forms back in. So again, it is really important. One of the things that we hear a lot from previous practices is having sort of a clearly designated person or process in which the way that this is going to happen. But you definitely want to be thinking about how you're collecting those screening tools once you have them or once you use them, and who's going to be collecting and who's going to be kind of keeping tabs on where they are. Remember, you're doing them for all of your well visits in that 0 to 12 month mark. And then it's a matter of getting them over to the GRC, which is the group that does the actual data tabulations for us. So Sam already did mention that form earlier on. That's basically the front sheet, the fax cover or the scan cover, depending on which process that you're using, but you can fax them or scan them, whichever seems most doable for your practice. It is really important though that you're documenting on here if these screening tools are coming from last week. Well, how many well visits did you have, well visits from 0 to 12 for the number of providers that are participating in the program in your clinic? How many well visits did you have, so that we can actually sort of get a sense also of, have we gotten the right number of well visits, and do we see maybe an issue in terms of just getting them done consistently? And then once you scan them or fax them over to GRC, you just get to sit back and relax, because that's when you'll hear from us in terms of feeding back to you the results that we're seeing based upon the data on the scanned forms. And those monthly action period calls that Mike was mentioning in the beginning, part of those action period calls are designated times where we're going over the data as well for the clinics.